Good evening, everybody. Welcome to the classroom series. Now we have Dr. Seham Saida. She's a consultant in MS Ramaiah Institute of Neurosciences. She's going to give a talk on neuroprognostication after cardiac arrest in neurointensive care. And over to you, ma'am.
Yeah, good evening, everybody. I'm going to talk about prognostication after cardiac arrest in a neurointensive care. So this is a case scenario which we commonly encounter. A 50-year-old man who collapses while jogging through the park. A bystander finds him unconscious without a pulse and he starts CPR and calls an ambulance nearby. On arrival to his emergency room, you see that he's in ventricular fibrillation. Resuscitation is continued and severe acidosis is noted. ROSA is re-established, but he still remains comatose with absent pupillary reflexes. He's then shifted to neurointensive care and he's treated with hypothermia to achieve a core temperature of 34 degrees centigrade in first 4 hours, within 4 hours, which is maintained for 24 hours. And he's rewarmed subsequently, but still remains unconscious. So what is the big question is how do you advise regarding the neurological prognosis of this patient to the patient party or the surrogate decision makers for the patient? As we know that the cardiac arrest is a devastating event both for the family and the patient. Despite improving resuscitation practices, the mortality rate for those who suffer out of hospital cardiac arrest is as high as 90%. And 50% of these survivors are left with severe neurological impairment. In-hospital arrest has slightly better outcome when compared to out-hospital cardiac arrest, with about 44% having ROSC and survival to discharge is around 17% of these patients. Withdrawal of life-sustaining treatment is one of the most common cause of death in these patients due to the poor neurological outcome. So why is neurological prognostication important? This forms one of the central components of post-cardiac care arrest. And firstly, the families of the surrogate decision makers can develop a realistic expectation and make plans about ongoing intensive care. And it is also at most important to have a neuroprognostication done accurately in order to avoid both pursuing futile treatment in patients designed for a poor outcome and making an inappropriate VLSC, that is withdrawal of life-sustaining treatment in patients who may have a chance for neurological recovery. Post-cardiac arrest brain injury is one of the most common cause leading to death and long-term disability in those who survive it. The pathophysiology includes a primary ischemic injury and a secondary repopulation to the ischemic brain, which sequentially occurs during cardiac arrest, resuscitation, and post-resuscitation phase. So the first ischemic pathology includes where there is decreased cerebral blood flow causing ATP depletion, resulting in dysfunction of sodium-potassium ATPase pump, causing massive influx of sodium intracellularly, which also causes influx of water, leading to cytotoxic cerebral edema. And accompanying with it is potassium efflux and membrane depolarization, leading to increased opening of calcium, voltage-gated calcium channel, leading to increased intracellular calcium. This calcium in turn increases the release of excess neurotransmitter like glutamate, which causes further increase in calcium from the endoplasmic reticulum. The increased intracellular calcium can enhance lytic enzymes like caspases, phospholipases, and proteases, causing cellular damage. And it also disrupts the mitochondrial electron transport chain, leading to increased release of reactive oxygen species. All this together causes increased damage, which further leads to increase in the neuroinflammation in microglia and astrocyte activation, releasing of interleukin 6 and interleukin 1 beta. So what is the ideal time of prognostication? In guideline, it is recommended that any prognostication should be deferred at least for 72 hours post-ROSC if the patient is not treated with hypothermia. However, if the patient is treated with hypothermia, then at least 72 hours following rewarming, the prognostication should be delayed. And any assessment should be performed in absence of confounders like sedation, hypothermia, or electrolyte and metabolic abnormalities. What are the different prognostication modes? There is a multimodal prognostication mode used. One is the clinical examination. Second is the neurophysiology, assessment of serum biomarkers, and imaging modalities. The clinical examination includes the motor response, eye reflexes like pupillary reflex to light and corneal reflexes, and presence and absence of myoclonus. It is recommended that the guideline tells the presence of an absent response or stereotactic or decorticated flexion, abnormal flexion, or extensor response to pain. That is a GCS of motor response less than equal to 10, which is at more than 72 hours after ROSC, is a non-specific but a very sensitive sign of poor neurological outcome. However, the assessment of motor response needs the application of a strong stimulus and also exclusion of all the residual effects of pharmacological sedation and neuromuscular blockers. Pupillary light and corneal reflexes. Bilateral absence of pupillary light reflex at 72 hours following ROSC is a robust indicator of poor prognosis. Whether or not the patient undergoes TTM, it has a high false positive ratio and a very narrow confidence interval. So the predictability is very high with absent pupillary light reflex. Absence of corneal reflex is 72 hours also correlates with poor prognosis. However, this does not have this has high false positive rate, that is around 5% when compared to the pupillary light reflex. Newest modality used is the automated pupillometry. This is a quantitative automated pupillometry which is accurate even when the qualitative pupillary light reflex is unable to be reproducible. The index used here is the neurological pupil index, which takes in consideration it's a combined index which combines size, construction percentage, construction and dilatation velocity and latency, which can accurately predict the poor neurological outcome as early as 24 hours from ROSC, and it is preferable over a normal standard pupil assessment. Myoclonus. These myoclonus are sudden, brief, involuntary jerks which are caused from muscular contraction or inhibition. There are certain criteria of myoclonus which is associated with poor neurological outcome. The myoclonus which occurs early, that is within 48 hours of ROSC, those which are generalized and has a synchronous and stereotype pattern, and those which are prolonged, that is more than 30 minutes, like they're called as status myoclonic epilepticus, and those myoclonus which are associated with malignant and unreactive EEG patterns, which I will be discussing further. These are associated with poor outcome. However, this should not be confused with another syndrome, that's Lance-Adams syndrome. It's a form of action myoclonus which occurs during voluntary movement. This is usually seen in survivors, and this is associated with good neurological recovery. Amongst the electrophysiology monitoring, we go ahead with EEG and somatosensory evoked potential. Why EEG? Because it is widely available and it is non-invasive, inexpensive, and it provides a real-time investigation of the electrical brain activity. So the American Clinical Neurophysiological Society has published certain guidelines so that the EEG to interpret the EEG and validate the setting of prognostication. So this includes three main factors to be seen. That is the background EEG pattern, presence of superimposed discharges, and how is the EEG reactivity to any stimulus. There are three malignant EEG patterns which when present in any patient, it is supposed to have a poor prognosis. The first pattern is the suppression without discharge. Suppression is where the entire EEG has low voltage complexes, where the voltage is less than 10 microvolts. And if this pattern is seen anywhere, it is associated with poor outcome. It's seen at 24 hours. Other malignant EEG pattern is suppression with discharges, which is generalized suppression which has periodic discharges. And the third malignant EEG pattern is burst suppression. And with burst suppression, there are two important types. One which has identical bursts. So there's suppression where most of the EEG lies more than 50% of the EEG is in suppression along with burst. So where the first 0.5 seconds or more of each burst is stereotype cluster, which is visually similar to each other. That is two clusters appearing visually similar, and those which are having high epileptic form bursts for more than 50%, these are associated with poor outcome. Background reactivity. EEG background reactivity, a stimulus is applied, either a painful stimulus or an auditory stimulus is applied. This EEG changes considerable. There is a measurable change in the amplitude and the frequency when a stimulus is applied. So this is measured. So normally the EEG to be reactive, there will be a change either in the amplitude or a frequency. So absence of this change or the absence of reactivity is associated with poor outcome. But however, the limitation of this is that it is a highly subjective in its administration. The type of stimulus used, the strength of the stimulus, and the frequency used, and also the assessment of EEG recordings. The intervariable reliability is very less because of the variation. So this is the EEG seen from a post-cardiac arrest patient. The EEG shows predominantly alpha rhythms. When a painful stimulus is applied, there is no change either in the frequency or the amplitude of the EEG, which is depicting iptomalignant pattern, which is a non-reactive EEG. Here you see when a stimulus like a clap or an auditory stimulus is applied, there is change in the amplitude of the EEG. There is attenuation. So this is a normal response. Electrographic seizures. So all seizures are not associated with poor neurological outcome. There are certain seizures during ECG which are associated with poor neurological outcome. So ACNS has defined them as unequivocal seizures. These are generalized rhythmic spike in wave discharges which has a frequency of more than 3 Hz, or those which clearly evolve any type of seizures which are more than 4 Hz. And electroclastic status epilepticus, it is an electroclastic seizure which is lasts for more than 10 minutes at a point, or the total duration is more than 20% in a 60-minute recording. So what constitutes poor neurological outcome is when the seizure occurs early, that is during the first 12 to 24 hours after ROSC, and is associated with some unfavorable or malignant changes in the EEG, when there is unreactive EEG or EEG background is suppressed. So such cases are associated with a poor neurological outcome. Somatosensory evoked potential. The recommendation is the bilateral absence of N20 wave after stimulation of median nerve, the response which is taken from the primary somatosensory cortex. If there is preservation of response at Erb's point and the cervical point, an absence of response in the primary somatosensory cortex with the test performed after 48 hours of ROSC, this is a reliable predictor of poor functional outcome. So this is the normal response after stimulation of the median nerve. The recordings are taken at the Erb's point and the high cervical point, where you see the N9 response, N30, and the normal N20 response from the primary somatosensory cortex. However, where there is absence or reduced amplitude of N20 bilaterally in patients with poor neurological outcome. The next modality used for prognostication is serum biomarkers. So these are released after brain injury. They can be released from the neuron cells like NSC and UCHL1, or from the glial cells, or from the axons like NFL, that is neurofilament. The most commonly used is the neurospecific enolase in prognostication. So these concentrations, along with the malignant EEG changes, they correlate positively with the extent of the neuronal injury. The recommendation is it has a poor outcome if the level is more than 60 micrograms per liter at the end of 48 to 72 hours. However, when you predict the outcome, it is important to see the trend of NAC concentration from serial measurements rather than a single value. It has certain limitations. One, because it is also present in the blood and hemolyzes a sample. If the sample is hemolyzed, it gives a false value, elevated value. And NAC is also present in other neuroectodermal cells like small cell carcinoma, and these patients will have spurious high values. The other biomarker used is the serum S100 beta protein. These are released by the glial cells after brain insult, and also from the extracerebral sources like adipose tissue and muscle. So this is done less constantly, one because of the availability of the test, and another because the threshold for the cutoff values is not uniform across the various studies. Now, however, a certain cutoff point where it is shown as more than 0.5 micrograms per liter is signals poor prognosis if it is found within first 22 hours of cardiac arrest. Neurofilament light chain protein. This is a cytoskeletal component released from the axons, that is from the large myelinated axon of the central and the peripheral nervous system. Increased blood values will correlate with severe neurological disorders like in stroke, ALS, and dementia. This is upcoming test, and it is found that it is with a highly sensitive technology like SIMOA. This has superior prognostic performance when compared to other biomarkers, and also the available methods, because it does not get hemolyzed. The sample does not need centrifugation. It has more prognostic value when compared to other biomarkers, and it is the second most sensitive biomarker after MSC. The other biomarkers are like serum glial fibrillary acidic protein and brain-derived neurotrophic factor and tau protein. Studies are ongoing, and the research is ongoing, but we have insignificant results to show that these can be used in prognostication. It has also been found that increased concentration of serum procalcitonin during the first 48 hours after reperfusion is associated with increased mortality and also with poor prognosis. For neuroimaging, brain CT and MRI is preferred. Early CTs should be done within 24 hours in order to rule out any intracranial hemorrhage. The changes which we see in poor prognosis are loss of gray white matter discrimination and sulcal effacement and edema due to cytotoxic edema. So the loss of gray white matter discrimination within first 2 hours of cardiac arrest is a reliable predictor of poor outcome. It was a qualitative assessment, and for quantitative assessment for gray white matter, you see the gray white matter ratio. For the gray matter, we take the sum of the coordinate nucleus densities, and for the white matter ratio, we see the sum of the internal capsule densities. And the ratio of anything less than 1 to 1.5 to 1.2 is highly specific for poor outcome. MRI has a high resolution when compared to CT. However, because it allows for easy identification of structural abnormalities in the neocortex, deep gray nuclei, and hippocampus, which are more prone for developing anoxic changes. The focus should be on diffusion-weighted imaging. The recommendation is that there's a diffuse pattern of restriction in diffusion on MRI, that is involving both anterior and posterior circulation and white and gray matter, and it should be performed between 2 and 7 days from ROSC. It is a moderate, so any restriction, diffuse restriction or diffusion restriction is a moderately reliable predictor of poor functional outcome. So you can see hyperintensities in the deep nuclei and in the posterior cortex with diffusion restriction. So what is a stepwise multimodal algorithmic approach for prognostication once the patient comes for a thing? So once the resuscitation is done from cardiac arrest, it depends on the team to undergo target temperature management and rewarming. And then the patient remain unconscious with a GCS, with a motor score of less than or equal to 3, and for more than 72 hours without any confounders, that is without sedation or muscle relaxation. Patient is not hypothermic, electrolyte and metabolic abnormalities are corrected. If the patient persists, then you have to see for the following signs. That is, there is no pupillary or corneal reflexes after 72 hours of ROSC. There is bilateral absence of N20 response on SCP. There is highly malignant EEG patterns, which is last after 24 hours, or serum biomarker like NSC of more than 60 mic per liter at 48 hours, and which concludes at 72 hours. Presence of status myoclonus, which is more than 30 minutes of myoclonus and EEG within 72 hours. Presence of diffuse extensive anoxic injury on CT or MRI. So any two of this are present, the answer for any of two of these criteria is yes, then the poor outcome is likely. However, if the answer is no, then it is suggested that we wait and observe. That is, you continue the treatment and then you conduct these tests again after 24 hours before prognosticating the patient. So this is a neuroprognostication algorithm from the AHA and Society of Critical Care Medicine. So once the ROSC is established and you see that the patient is following your command at any time, that is, he's awakening from the coma, that means it has a good prognosis. However, if it does not follow your command and you see that there's certain signs of meets criteria for brain dead, means he's not responsive, areflexic with no brainstem reflexes, then death is declared. However, if that is not the chance, then you see how if there are any signs of good outcome, that is motor response, either withdrawal or localization is present. MRI shows absent DW. There is no DW lesion 2 to 7 days after ROC, or the EEG which is continuous background or reactive EEG and presence of N20. That is, these are the signs of good outcome. So then you stop and continue treatment. However, you see if there are some predictors for poor outcome, like there is bilateral pupillary absent of bilateral pupillary reflex within for more than 72 hours after ROSC, or bilateral absence N20 waves or necessity for more than 48 hours of ROSC. So if the answer for both is yes, then there is likely that the patient is going to have a poor neurological outcome. There is no uncertainty. And if the answer for any of this is no, then you again see a CT scan, MRI, and EEG. So if EEG having suppression patterns or periodic discharges, if MRI again shows hyperintensity or the diffusion restriction, then there is, if the answer for this is yes, then there is poor outcome. However, if it is no, then you again assess the patient again. So what are the predictors of good outcome? All these are predictors of poor outcome, poor neurological outcome after cardiac arrest. So if the patient presents with flexion or better response, anything better than flexion, response to painful stimulus, or there is presence of pupillary reflexes at 72 hours, though it's a not strong indicator for, but it is not a strong indicator, but has a good prognostic value. Benign EEG patterns are associated with good outcome. The one which is a continuous EEG, which has a background reactivity, a non-suppressed EEG without an epileptic form discharges, an absence of diffusion changes and brain MRI, and low blood values or biomarkers. All these are associated with good outcomes. To conclude, prognostication after cardiac arrest can be seen as an attempt to shed some light into the dark, has become an integral part of post-resuscitation care. And whenever you have to prognosticate, always use a multimodal model in order to prognosticate better to avoid death due to withdrawal of life-sustaining treatment. Thank you.
Everyone for watching. We will see the next session with a different topic. Thank you. Thank you so much.
Thank you.